we call lysosomal storage disorders, or lysosomal diseases. This is a collaboration of people here at the University of Minnesota Physicians, the Fairview Hospitals, and also our own Department of Pediatrics. So it's a cross-cultural, if you will, endeavor to take care of patients with these conditions. Now, of course, we have to have a disclosure statement, and one way or another, I'm tied in or financially beholden to a lot of people in the community. And this is something that we, in the field of lysosomal conditions, never had before. So we're actually quite grateful. In fact, this could actually be an outline for what we'll talk about today. Actelion, Amicus, BioMarin, Genzyme Corporation, they're all pharmaceutical companies, which means we actually have drugs now for these disorders. They're no longer entirely untreatable. Fairview is, of course, collaborating in this project. Pfizer, Protalix, or more pharmaceutical companies. We have here at the University of Minnesota 2 very large NIH grants. One is the Lysosomal Disease Network. We have a $6 million grant to network centers around the country on lysosomal disorders. And some of you are investigators on that nationwide, actually international effort. We also have a laboratory basic science research program, another $6 million program project grant that's been funded for 14 years. Shire Pharmaceutical is another company that's actually making drugs for some of these conditions and is actually investigating some of its new drugs here at the University of Minnesota with us. And then the Society for Inherited Metabolic Disorders is an academic group that pays me as a lecturer. Every year they put on a 6-day, pretty intensive course called the North American Metabolic Academy. And some of the slides, some of the information I'll show you comes from that course. I've even been asked to talk by the state of Texas, their genetics and newborn screening program as part of their CME course. The University of Minnesota has various entities which are contributing in one way or another to the research. Notice importantly, this presentation will discuss off-label use of FDA medications, and that'll become more apparent here as I talk a little bit. As I mentioned, some of the slides are from a course that we teach, part of our World Symposium. This course is a half-day course called Lysosomes 101. We did the first Lysosomes 101 course last year at the 8th Annual World Symposium. World stands for We're Organizing Research on Lysosomal Diseases. This is now the University of Minnesota's largest CME course. We put on a half-day course as part of this larger scientific research meeting to talk about the background, bring everybody up to speed on lysosomal diseases. And now I'm just not going forward. There we go. This happens to show some of the centers that are involved, these centers that are involved in our NIH-funded lysosomal disease network. And it doesn't want to move on. Please move on. I'm having a little technical problem here. Oh. Go to slide number. It's too fast for me. There we go. Here's a brief comment, if you will, about the Society for Inherited Metabolic Disorders, NAMA course, North American Metabolic Academy. This is how generally fellows or early stage specialists in metabolic disorders get trained over a 6-day course in that area. So let's talk about a cell. That's where this all begins, in the lysosome. That organelle is depicted right here. That's the digestive vacuole of the cell, and it has some rather specific or important characteristics that make it, that give us some commonality in the pathophysiology of the diseases, but also in the way we can treat these conditions. And historically, we've thought about this concept, the cytotoxicity hypothesis. It goes as following, that the lysosomal, and some people use the word storage diseases, which that's now, if you will, becoming less relevant, are caused by the deficiency of one lysosomal acid hydrolase, resulting in the accumulation of a single major substrate normally degraded by that enzyme. Following that buildup of non-degraded primary substrate, the endosomal lysosomal system is overwhelmed and cells simply die. That was the belief or the philosophy or the motto we've used for many years. Heterogeneous neuronal and glial cell types exhibit distinct metabolic identities. They're different from a lot of different cells. Many of them are involved in lysosomal conditions. The type of storage material and its cellular location vary from disease to disease. Most exhibit activation of microglia in the brain. Events triggering the inflammation are poorly understood. This greater endoplasmic lysosomal system plays a potential role in signal transduction and in cellular homeostatic control in the brain. So there may be things more than just storage of a material that are toxic to the cell or causing the pathophysiology. We know that there are actually more than 50 soluble membrane proteins involved in lysosomes. Those are acid hydrolases. That was the first group of proteins that we have thought about for lysosomal diseases. There's also Golgi or endoplasmic reticulum, enzymes responsible for trafficking or catalytically activating specific lysosomal enzymes. And some examples of the diseases that result from defects in these genes and proteins are ones you know, glycogen storage disease type 2 or Pompe disease, the sphingolipidoses, neutrolipidoses, glycoproteinoses, mucopolysaccharidoses, pycnodysostoses, Batten disease, also known as ceroid lipofuscinosis. So there are a variety of clinical conditions that result from these defects. More than the soluble and membrane-associated degradative enzymes are involved. For instance, we talked about Golgi and ER enzymes that are responsible for trafficking these enzymes and activating them. For instance, the diseases called mucolipidosis type 2 or type 3, also known as pseudo-Hurler polydystrophy, and eye cell disease are responsible for erroneous trafficking of enzymes to their normal lysosomal localization. Alternatively, another disorder, multiple sulfatase deficiency, results from an enzyme that is missing that should activate 15 different sulfatases in the body, yet it still causes a clinical phenotype that is very similar to things that you're probably more familiar with, like Hurler syndrome. There are also other non-enzymatic defects causing lysosomal diseases. The sapacins are critical for aiding in enzymatic degradation of glycolipids, and there's some sphingolipidosis diseases that result from defects of those proteins. Cholesterol binding in the NPC2 gene. There are also membrane-associated proteins such as the NPC1 protein, mucolipin-1, and proteins associated with autophagal lysosomal fusion of lysosomal control. Each one of these enzyme or protein rather, and gene defects can cause a specific phenotype, but there's also a great deal of overlap. Notice that NPC2 gene and NPC1 gene, entirely different proteins with entirely different functions, cause the same clinical phenotype, which for years and years and years we've called Niemann-Pick disease type C. Niemann-Pick type C disease can also result from a defect in proteins involved in lysosomal pH control. It's becoming a very complex and heterogeneous pathophysiology to explain the clinical phenotypes that we've known for many, many years. So let's talk about some of those lysosomal diseases. This is a nice study published in JAMA. It was a survey from Australia between the years 1981 and 1996. They looked at the frequency of known lysosomal diseases in that country. There are only 2 laboratories, 2 clinical centers that serve all of Australia, so they could capture pretty much all of the known disorders in that geographic region. So we see here's Hurler syndrome in the milder form, Shea syndrome, MPS 1. We see Gaucher disease is listed as the most common lysosomal disorder. There's others that are more rare, Solid disease, Wolman disease, GM1 gangliosidosis, Niemann-Pick A and B, and so on and so forth, Tay-Sachs, cystinosis, MPS IVA, Morquio syndrome, Pompe disease, Krabbe disease, Hunter syndrome, Fabry disease. So we can see that individually they're all very, very rare. Cumulatively, they're probably 1 in 5,000 births in most populations. And here again is a list of some of the more common names, but even this list of, I think it's some 36 disorders, really does not encompass the entire spectrum of known conditions, and certainly within each one of these there's also a great deal of heterogeneity. For instance, Tay-Sachs disease having both severe infantile forms, intermediate juvenile forms, and then late onset forms that affect adults with normal intellect. So you can see it's a very heterogeneous group of conditions. Traditionally, we've classified them by the chemical that accumulates, the first chemical abnormality that was identified, and therefore suggesting a common pathway, a common metabolic pathway that was involved. So we know of the glycosphingolipidoses, Gaucher disease, Fabry disease, the gangliosidosis, Tay-Sachs disease, GM1 gangliosidosis being examples. The mucopolysaccharidoses, one that we're very familiar with here is Hurler syndrome in its more attenuated form, Shea syndrome. The glycoproteinoses such as mannosidosis and mucolipidosis 2 and 3. Carbohydrate storage disease, the primary one being Pompe disease. And then there's also membrane and transport defects like Danon disease due to defects in the LAMP2 and LICNL1 genes. If we look at one group and drill down a little bit more into that heterogeneity, let's look at the group of glycoproteinoses. These are defects in post-translational modification of lysosomal enzymes. We talked about eye cell disease and pseudo-Hurler polydystrophy. There are also defects in glycoprotein degradation that result in things like aspartoglycosaminuriria, fucocytosis, manocytosis, sialidosis. And then there's galactosialidosis. So this is one category, all defined based on our early understanding of what the pathologic substrates were that are accumulating. So what's the path to diagnosis? Well, first of all, it's us, right? We have some sort of clinical suspicion. There's something wrong with a child that makes us think, perhaps in the general pediatric office, I've got to do something more than just send them, come back for their regular well child check. And in fact, it's usually, in my experience at least, one unique finding that is troubling us. There's something that's just not right about one child. But if we look a little bit further and we look at that child very carefully, we find often there's a cluster. There's more than one thing going on in that child. And that should be the tip-off, not to wait, but to go ahead and get a consultant or do more tests or try to examine the underlying etiology, explore the pathology a little bit further. Now here, I'm doing something we didn't used to do 20 years ago. I'm using the word urgent. I'm saying any kind of abnormality like this probably deserves urgent referral. And the reason I use the word urgent is because now there's treatment. And if we delay treatment, the disease continues and it may be irreversible. So a geneticist or metabolic specialist is often a good place to go for help. And of course, the university is a great place to come for this sort of thing. And our goal then is to have definitive diagnosis. Typically, we'll do enzyme assays if we know or suspect a particular condition. But we don't usually stop there. We want to try to describe the biochemical abnormality in a very comprehensive way. So if it were, for instance, a mucopolysaccharidosis, we'd also want to know what the urine GAG level is. We would also do DNA testing. Just about every gene now is known to have a mutation involved that is causative. So we want to be very comprehensive in identifying the disease and do it quickly. Why? Because of treatment. So traditionally, what has treatment been? It's been enzyme replacement therapy. This is all derived from an important observation in the 1960s. Liz Neufeld at NIH was one of the key people who discovered this. Bill Sly at University of Washington University in St. Louis contributed as well. But we recognized that if we have a cell with lysosomes, and here's the lysosomal storage material accumulating, that if we supplied the enzyme exogenously in the plasma or in tissue culture fluid, that enzyme would be taken up by specific receptors. For most lysosomal disorders, it's a mannose-6-phosphate receptor. So all of these lysosomal enzymes have a mannose-6-phosphate sugar that's on the outside of the protein. For Gaucher disease, it's actually mannose, plain mannose. But all of the lysosomal enzymes have some address label, which is a carbohydrate on the protein. And the value in that as a therapy is that these are rapidly taken up into lysosomes, and guess what? That's exactly where the enzyme needs to be to degrade the accumulating substrate. The difference is it's not being supplied endogenously by the cell itself, but we exploit the possibility of providing the enzyme exogenously, having it being taken up externally, and still getting the same metabolic effect in the cell. So many of you know that in the 1980s, we were the first institution in the United States to explore hematopoietic stem cell transplant. We called it bone marrow transplant back then, but we now know we can get stem cells from other places like umbilical cord. Even to this point, doing 10 transplants per year here, we recognize that it is not entirely a cure. It's not a completely successful for every aspect of the disease. Nevertheless, it is the standard of care. We recognize, though, that the disease continues to progress, even in Hurler syndrome, in a successfully engrafted child. Corneal clouding, heart valve problems, musculoskeletal pain and stiffness, those are improved perhaps somewhat, but not resolved. And of course, there's continuing short stature. So this is kind of a home run. Bone marrow transplant is. But the game's not over. There's a lot more that we can do. And the pharmaceutical companies have become very involved, having recognized the therapeutic options and, importantly, the business options. And so now we actually have a quite large number of drugs that are available for some of these disorders. So the first drug to be approved for Gaucher disease was approved by the FDA in 1991, based on an FDA clinical trial that included only 12 patients. 12 patients, led to FDA approval of alglucerase. This was an enzyme that was made by importing placenta, human placenta from Italy, bring them into Cambridge, purifying the enzyme in a factory, and then making an injectable drug. 3 years after that, recombinant DNA technology had advanced such that they could make that same enzyme in Chinese hamster ovary cells in a factory. So they're no longer importing placenta. In fact, a lot of these other drugs now that are being made by that or a similar technology. Having recognized the success not only of the drug made by Genzyme in this case, but also the market potential, other small biopharmaceutical companies have become involved. So in 2010, a competing company, Shire, is making veloglucerase, basically the same enzyme, but made in a cultured human fibroblast in a factory. And just this year, an Israeli company is making the same enzyme made in carrot cells grown in a factory in Israel. FDA approved this year, talglucerase. For Pompe disease, glucosidase alpha is now available, intravenous infusion. For Fabry disease, agalsidase beta was approved by the FDA in 2003. A competing drug, virtually the same thing made in a different cell line, went to the FDA for orphan disease approval on the very, very same date. But they did not get orphan disease approval because they did not meet their clinical endmarks. This was the first time when two drugs were going head-to-head for orphan disease approval, knowing that only one drug would get approval. And I didn't know how that was going to come up. It was interesting to watch. I don't know how the FDA would eventually deal with that, but in this case, they did not meet their end marks for the second drug. So agalsidase alpha is not available in the US, although it's available in Europe as Repligal. Other companies are working on drugs for Woma disease and cholesterol storage disease. We know for mucopolysaccharidosis, hyaluronidase is available for MPS I, for Myotolome syndrome, galsulfatase, Hunter syndrome, idursulfatase. We'll talk about that more here momentarily. Another drug for Morquio syndrome type A is being tested right now in clinical trials. And here at the University of Minnesota, we're doing the natural history studies for Sanfilippo syndromes type A and type B, hoping that down the road that natural history study will be the control data for which the company looks at efficacy of its drug. Notably, some of these drugs won't work intravenously. So those with asterisks are administered intrathecally by a CNS delivery device. So that's the history, the track record, the origins, if you will, of enzyme replacement therapy. Recognition that a protein properly glycosylated can be picked up by a cell, wind up in the lysosome, and can be used as a drug. But other people have been creative in thinking that may not be the only way to treat these disorders. So one company called Amicus has developed a series of drugs, the AT series here, and they're working on small molecules that will decrease the substrate accumulation or increase the activity for Fabry disease or Pompe disease or Gaucher disease, and they have some other things in the pipeline. Some of their early work recognized, much to their surprise, that these drugs would actually work best in combination with another drug, enzyme replacement therapy. So as they're doing these various studies of small molecules, we're finding out that combination therapy may be more efficacious than just any one single drug. There are other small molecule drugs. One that's FDA approved now called Miglustat, sold under the brand name Zavesca, is approved for Gaucher disease. But we also have used it off-label for some other disorders, such as Tay-Sachs disease, and it's actually approved in Europe for Niemann-Pick disease type C. So this particular drug works at inhibiting the synthesis of gangliosides and other glycosphingolipids, and it's the potential for working on many different disorders, although it may be FDA approved for only one particular indication. We talked just briefly on the previous slide about chaperone therapy, molecules that might stimulate or enhance the activity of a native enzyme or a drug that's given intravenously. We've also had some other interesting sort of scientific innovations that maybe haven't come to full fruition. For instance, pyrimethamine is actually a drug used to treat cerebral malaria. So patients who have a very, very bad malarial infection can get the FDA-approved drug pyrimethamine. Curiously, though, it acts as a chaperone for hexosaminidase A. So it's been explored for treatment of Tay-Sachs disease in late onset form especially. I've thrown this one in here. This is not for lysosomal diseases, but just to illustrate the chaperone concept, sapropterin dihydrochloride. I think Dr. Utz has presented at a previous grand rounds here, and she just in February presented her data at the NIH at a PKU conference. This drug is helpful for about 50% of patients by boosting phenylalanine hydroxylase activity, lowering phenylalanine levels, minimizing the dietary restriction that people with PKU have to survive. have to deal with. There's another drug that's very interesting. For those of you who remember what a stop codon is, you may also remember that aminoglycosides work in bacteria by making the bacteria read a codon wrong. And so this concept has been exploited with a drug called PTC-124 by a company called PTC. For instance, if we know that Hurler syndrome, the most common mutations are stop codons, but this drug can make the cell misread that stop codon once in a while, make a little bit of enzyme. This drug has the potential for working not only for any disease which they've tested on, but any disease that has a stop codon. Their initial target actually was for Hurler syndrome, but they're actually going for FDA approval for Duchenne muscular dystrophy. So how about clinical manifestations of lysosomal diseases? Many of you will see a child like this maybe, and at least in a textbook, perhaps on the ward, and you'll recognize a child who is weak, has cardiomegaly. You'll be thinking about the infantile form of Pompe disease, neonatal hypotonia and cardiomyopathy, and that's what would probably be on the board's exam. However, if you look more carefully, you'll also find there are juvenile onset patients, individuals who are maybe in their teens, and they're actually diagnosed with muscular dystrophy, something that mimics scapulohumeral or Duchenne muscular dystrophy. Looking more closely, doing the right tests, one finds out that those people also have an enzyme defect. It's not really muscular dystrophy. It's a later onset or attenuated or juvenile form of Pompe disease. And they're also adults. We know of one family that sent their 2 kids off to college, obviously very smart boys. In the first year, the first month actually of college, had a psychiatric break and were subsequently diagnosed as having a late onset form of that disorder. So this is the kind of child that we'll see around here a lot. Hepatosplenomegaly, contractures, coarse facial features, and we think of mucopolysaccharidoses. We test for that by looking at their urine mucopolysaccharide level, and of course the disorders take their name from the mucopolysaccharide or glycosaminoglycan that's accumulating. These were among the first lysosomal disorders described clinically, and first identified in 1917 and 1915. The patient we probably don't see on the ward here is a woman like this, a woman who's been followed in the outpatient eye clinic because she has mild corneal clouding. And Mariella Pierpont says, this patient has arthritis also. Could that be something more than just contractures of the fingers and corneal clouding? In fact, that's the late onset form of mucopolysaccharidosis type 1, the same enzyme defect as Hurler syndrome in a milder form known as Shea syndrome. Actually, for your interest, it was discovered by a medical student, a previous medical student at the University of Minnesota, Harold Shea, who then donated money to the University of Minnesota, and that's why we have the Shea Chair in Ophthalmology here. But that's held in contrast to children with Hurler syndrome, even though they have the same enzymatic defect, just quantitatively different physiology or pathophysiology, biochemistry. Here's another individual with short stature and obstructive airway disease. That's Hunter syndrome or MPS II. These disorders can be severely affecting the brain. In fact, these 2 mentally retarded children died about age 15. Even though they're wearing, their graduation boards, they had severe progressive brain involvement. But not all patients will have that kind of neurologic defect. Let me segue to a particular situation here that illustrates not only some of the diagnostic ways we get to this to therapy, but the consequences of therapy. And so I'll tell you about a 9-month-old child here. The primary care provider became concerned about Peyton's development and excessive weight gain. Peyton was sent for the physical therapy consultation. By 12 months of age, Peyton had returned to his primary care physician for a well-child checkup, and the follow-up concerns were about his developmental delay and obesity. Peyton was again found to be a large child at the 97th percentile for height, weight, and head circumference. And by 13 months, a month later, there was ongoing growing concern about his developmental delay and scoliosis and obesity, as well as chronic upper airway congestion. The facial features seemed much more dysmorphic as he got older. This raised concern about a possible mucopolysaccharidosis condition. And so the primary care doctor called a geneticist who suggested x-rays and a rapid diagnostic test. The x-rays showed lateral lumbar spine with dysostosis multiplex, and that supported the diagnosis of a mucopolysaccharidosis condition. Concomitant concerns about Peter's upper airway obstruction led to referral to an otolaryngologist, And in fact, once the group started looking at the patient, we started seeing the first tests suggesting a mucopolysaccharidosis condition. Markedly elevated urine glycosaminoglycan or mucopolysaccharide compared to the normal reference range, which is less than 45. We do the secondary test, the plasma enzyme level, and find, in fact, no enzyme is present in plasma. Go ahead with the third test, aryl sulfatase B in leukocytes. Now, I don't know if you understand the logic behind this, but we also want to rule out other conditions that can simulate Hunter syndrome. In fact, I mentioned earlier a condition, multiple sulfatase deficiency. If one has multiple sulfatase deficiency, a different genetic defect, there'll be deficiency of 17 different sulfatases. So by doing this other sulfatase enzyme and finding its levels were normal, we validate the fact that iduronate sulfatase is pointing toward Hunter syndrome. So we want to do one more thing, and that is sequence the gene. I argue that all these tests should be done immediately to be sure we have the right diagnosis. When we do that, our world is turned upside down because this fellow has an entirely normal IDS gene sequence. He's clearly missing the enzyme. He's making lots of urine mucopolysaccharide, and he still has a normal gene as best we can tell. So when this kind of dilemma happens, the onus is really upon us to examine that very carefully. The initial DNA sequencing was done in my lab, and that was normal. I thought maybe we made a mistake, right? So we sent it off to another laboratory, and they get the same result, normal DNA sequence. We went back and sequenced the gene SUMP1 for multiple sulfatase deficiency. That was normal. We even sequenced, as a research project, the IDS promoter, saying perhaps the mutation is somewhere not in the normal coding region, but in the promoter, and all of those were normal. So we're left with a situation that is not very satisfying, and have to ask some questions, and this is important for everybody to understand. How many patients with, for example, Hunter syndrome have mutations that are not found by sequencing the coding region in the promoter? There are at least a handful. And we have to look at other methods for doing that. And why do we bother? Well, because there's more than this child who are involved. In fact, this family did want to have more children, and the only way of doing prenatal diagnosis realistically would be by looking at the DNA. So this is the pathway of treatment, and I'm going to say also monitoring, because we forget this so often. We do a treatment, a transplant, we start them on enzyme replacement therapy, we say the child is cured, or at least they're getting optimal therapy, and we're done. But I would say that's not where our responsibility ends. We did these diagnostic studies to come up with Hunter syndrome in this case, and we're putting the patient now on IV iduronate-sulfatase enzyme replacement therapy. But what will the long-term outcome be? We're not going to know unless we monitor. So these are the kinds of things that I would recommend: monitoring urine glycosaminoglycans, looking at their overall clinical status, and actually monitoring for anti-elaprase antibody. Curiously, in our very own clinic, I got an email this past week saying, you know, we've got these antibody kits up in the lab up in 12, and they're research. Let's get them out of here so the CMS inspectors, you know, don't find research stuff they shouldn't have. And I pointed out, no, wait a second. This is vitally important stuff. And here's why it's vitally important. We're giving this patient weekly iduronate-sulfatase or elaprase enzyme intravenously in our clinic. And initially, Peyton's urine gags decreased toward normal. That's the therapeutic response we'd expect, right? After 2 years of therapy, Peyton has transitioned to home infusion. So he's even further away from us. He can be in the comfort of his own home getting IV infusions. Because the urine gags and clinical outcomes seem to be less effective a little bit later, the ERT dose was increased, so we can modify drug dose beyond what's on the label. That's what we thought would be the solution. But after 3 years, the urine gag was clearly climbing, and we find now that the anti-iduronate-sulfatase antibody titers were increasing. And in fact, we find now there was a neutralizing antibody that had been detected. In fact, this is the laboratory report from that patient. And you can see what's going on here. If you take plasma from this patient and put it in an assay to find out how effective that drug you're giving is, you'll see that either 96 or 100% of it is inhibited. So you're giving a patient a drug that costs $100,000 to $200,000 per year for the rest of his life, and he's making antibodies that kills it off, just like hemophilia. So what do you do? Well, looking at the FDA label, you can realize that this was not entirely unanticipated. Sera from 4 of the 32 patients that were studied in the initial FDA clinical trial confirmed that anti-iduronate-sulfatase antibodies were positive and were found to neutralize the enzyme in vivo, or rather in vitro. Patients who developed IgG antibodies at any time had an increased risk of infusion reactions, including allergic reactions. This patient did not have those allergic reactions or infusion reactions. Nevertheless, we're concerned about this. The reduction of urinary GAG excretion was less in patients with circulating anti-idursulfatase antibodies. So it really implies that the relationship between the presence of idursulfatase antibodies and clinical efficacy is unknown, but is obvious. If you kill off the drug, it's not doing any good. So Dr. Utz, a member of our Advanced Therapies clinic, came up with a tolerizing protocol analogous to what we do in hemophilia. And while we're initiating this, patient experiences a 3-week period of intermittent somnolence, lethargy, and irritability. And so one of the things we do annually on these patients is do a spinal tap. We're looking for hydrocephalus. Remember, giving an IV drug is not going to get across the blood-brain barrier. And these patients are still at risk for central nervous system disease, like hydrocephalus, cervical cord compression. And so in that case, when we measure the lumbar spinal fluid pressure, we find out it's very elevated at 54. And he does have papilledema. So further information that not only is the antibody present and killing off the enzyme, it's actually not being effective intrathecally. So after the parents' request, we do a brief trial of acetazolamide, and that reduces the spinal fluid pressure a little bit, but overall he's maintaining high pressure. So finally, neurosurgery places a ventricular peritoneal shunt with a marked clinical improvement, allowing the patient to be discharged. And the tolerization protocol continues at home, hoping that it will have some impact. In fact, now we're finding that it's only 86% inhibiting, and he's getting some benefit from the drug, but I think that tolerization protocol is just getting started, and we'll have to see how much further it goes. So the point of all this is to recognize that, yes, we have treatments for these disorders, but we have to continue to monitor them, and these are some of the things for this particular disease we monitor. Each disorder will have its own. We don't know the ultimate outcome. We may have to go through additional procedures like tolerization or even multi-drug therapy. Let me conclude with just a few more cases to kind of give you a little broader spectrum of disease, things to look for. Here's 2 brothers, and they're found to have clonus. Cervical cord compression is what one would expect in this particular condition. In fact, they're known to have Marteau-Lemay syndrome, but never really recognized that their cervical cord is slowly, day by day, month by month, being squeezed by mucopolysaccharide in the meninges in the neck. And so there's the stuff that's doing the damage. If we do a peripheral smear, we can sometimes identify those patients. Switching to another disorder, Fabry disease. One thing we've realized over the years is that one of our prior department members, Bob Desnick here, became world famous by recognizing patients with this kind of skin lesion, angiokeratomas, have a disorder of alpha-galactosidase deficiency, have Fabry disease, they go into renal failure, and it's treatable. But not every single patient has these. We've seen patients with absolutely none of these skin lesions, so they're often hard to find. We have to be very careful and look thoroughly. In the eye, we might see conjunctival vessels that are highly chaotic in their pathway. We might also see this very, very, very faint stellate corneal opacification. Usually an internist or a pediatrician would not see that. It probably takes an ophthalmologist with a slit lamp and a microscope to really see it. We talk about other disorders, and I think I mentioned earlier that we're doing a natural history study of Sanfilippo syndrome. This is some historical interest to people here because Dr. Sai Sanfilippo was one of our faculty here, and he was the first one to identify it. It's a disorder much like childhood Alzheimer's disease. Early on, there are signs that appear to be presenting in the first or second year of life with some subtle learning, developmental, and behavioral problems. By stage 2, children are becoming mute, and the dementia follows by age 6 to 10 with inability to follow any oral directions. By end stage, stage 3, there's no language at all. There's poor motor control, if any. Behavioral symptoms diminish, which is nice because you're not having to fight with the child all the time, but eventually they become totally dependent and essentially enter a vegetative state. So this is not a good disease. Neurodegeneration that progresses over 20 to 30 years typically. We now know there's not just one type of Sanfilippo syndrome, but 4, and maybe even a 5th type of Sanfilippo syndrome that's recently been discovered. Back in the late 80s, early 90s, we actually tried hematopoietic stem cell transplantation. And even though these children were successfully engrafted, we see as they got older, after transplant, their IQ continues to deteriorate. So we're not getting impact across the blood-brain barrier for this mucopolysaccharidosis, unlike Hurler syndrome. And what Shire has us doing now is trying to understand that by looking at various biomarkers in the cerebrospinal fluid, determining the pace of neurodegeneration and changes in the volume. And the hope is that at some point in the near future, we'll be able to give these patients therapy with an intrathecal enzyme replacement. We know that has been done experimentally for MPS 1, for MPS 2. There's actually clinical trials ongoing by the drug company. MPS 6, we've done the only patient here in the United States giving intrathecal enzyme to Martolomé syndrome. And of course, for Sanfilippo type A and type B, we hope that will happen sometime in the future. I already mentioned small drugs, and I won't spend more time on that. Let me conclude here and leave some time for questions, just with a reminder, though, that when there's a unique or important sign or symptom, looking at the patient more broadly and more specifically will often reveal a cluster of signs or symptoms. And that an urgent referral is important if there's a possibility of a lysosomal disease, because treatment is now available. So sending that person to a geneticist or metabolic specialist could be very important. And the studies should be very comprehensive, not simply measuring an enzyme, but doing any tests, including imaging tests, that help to find that disease and the problems. So at that point, it's a little bit early, but I think we've covered a lot of territory. If you'd like to ask any questions, let me conclude right there. Paul. Yeah, Scott McIver said you'd ask that question. Yeah, no, that's a very logical question. Yeah, the most common, Hunter syndrome is very unique and important and should be a good model, but as I just illustrated, even the DNA is not always definitive. There are a couple of special circumstances in Hunter syndrome where one can generally be pretty predictive. If there's a big gene deletion or insertion, and they're very, very common, then the gene is completely obliterated. It has no ability to make any enzymes. So you know those patients are going to have severe disease. There's another mutation, R468W, where arginine is converted to a, what's W? All of a sudden I'm blanking. That was initially reported to be always very, very severe. And I think that is probably the case, but there may be some exceptions to that. Most of the time, the genotype-phenotype correlation is pretty good. But of course, there's always exceptions.
Has anybody looked at immune suppression for patients who are developing antibodies to therapies, or maybe hiding the antigens that are causing the reaction by putting them in lysosomes?
In liposomes? Yeah, yeah. You know, both strategies have been taken to a greater or lesser extent. The patient I showed you with Hunter syndrome here is one of only a handful of patients that have ever developed antibody to elaprase. And Dr. Utz, do you want to raise your hand? She's our PharmD in our group, and she comes from a great deal of experience in cancer and hemophilia, and came up with a protocol really modeled after treating hemophiliacs that, you know, so far in a month or so seems to be working. There are others that have tried more caustic, if you will, chemotherapy-like immune suppressants, but then that exposes the patient to, you know, immune suppression and the risks of infection. So I think this approach is safer. Fortunately, those cases have been relatively rare, but as we treat more and more patients, I think it's going to be common. The other approach of encapsulating the enzyme is a little trickier, and it's not been done clinically in this situation. Most of these companies are happy just to get a drug approved, and then they don't have as much energy to deal with all the complications. They probably can't deal with all the complications. So it's left up to us to deal with that. But experimentally, enzymes have been encapsulated in liposomes. I mentioned PKU a minute ago, but we're still in the orphan disease world. And a company, BioMarin, has taken an artificial enzyme, an enzyme from fungus that breaks down phenylalanine by knocking the ammonia off it. It's not the usual way of getting rid of phenylalanine that our bodies use. We knock off the we put a hydroxy group on. But to get that fungal enzyme to be safe in a human being, they put about 3 to 6 polyethylene glycol molecules on top of it. And they're testing that right now. So, yeah, I mean, avoiding immune surveillance by modifying the outside of the molecule, liposome or chemically, is something that people have considered.
Jeff, is there any sense that patients with later onset disease like Shea get less antibodies than early does?
Janine, I don't know of any data. Well, would somebody, like someone with Shea syndrome who makes a little bit of enzyme, be less prone to making antibody against the drug? I mean, it makes perfect sense. I just don't know if there are any data. If you have a null mutation like Hurler's syndrome, then the drug is totally new, totally foreign. If you've got Shea syndrome, you're making a little bit of enzyme or an altered enzyme, maybe you're not as predisposed to making any. But I have not seen any data proving that. I think everybody assumes that, but I've not seen any data. It makes a lot of sense.
Yeah, I can't recall any data very. But that's kind of how we're trying to counteract it with the immune tolerance regimens.
Well, we're going to give an enzyme to patients, the early patients after transplant now. So, I mean, that's an open question is whether you're going to get enzyme.
Yeah. Well, what you got going for you is that a post-transplant Hurler child is making normal hyaluronidase. And molecularly, it's almost identical to the drug. And so the immune system they have, the donor's immune system, is seeing the drug, and will probably see it like it's enzyme that it's making. So I think your odds are pretty good of avoiding that problem. That's very exciting, by the way. And I don't know if you recognize it, but Paul and the others who have tried doing bone marrow transplant and initially giving IV drug and then giving intrathecal drug have really changed the world out there. And it's illustrating the concept that we might have a drug or a procedure that we think is dramatically efficacious when in the past there's been absolutely nothing. But now we're kind of entering a world more like AIDS or more like cancer, where we realize a good treatment may not be a cure. And there's still a lot more we can do. Well, thanks everybody for coming. Have a good afternoon.